To the next session. We'll change the tone a little bit, and we will move on to Dr. Borawong will come back. Have Dr. Borawong rest a little bit. We will continue with the next session. We'll come down to the branches, the embolization of a problem that we may have, and we will have panels to join us this morning. Is Dr. Somrat Thamtharawat is IR, interventional radiologist from Department of Radiology, Faculty of Medicine, Sirirat Hospital. Ajahn Somrat will join us as a panel, and we will have speakers. And I think type 2 endoleak and the branches coembolization is one of the key procedure for the success of endovascular therapy, either in thoracic or in abdominal segment. This morning we'll start with Dr. Soracha Rukhapan. Dr. Soracha is an interventional radiologist from Prince of Songkhla University. Will tell us a little bit about one of the issue that we heard a lot. It's the preemptive coils embolization in either thoracic or EVAR or TVAR, and tips and tricks for microcatheter. Dr. Soracha, please.
Thank you, Dr. Ajahn Bunprasit, and good morning, everyone. Thank you for the committee for inviting me to join here. Today, I will talk about the preemptive embolization to prevent the type 2 endoleak. The type 2 endoleak is the most common endoleak after the EVAR. We classify as the early or the delay by using the 12-month, or transient or persistent by using the result or not at the 6 months. And on the 5 years follow-up, the incidence is about 20 to 40%, and the persistent at type 2 endoleak at 2 years is about 10%. In the literature, there is a low risk of the rupture, less than 1%. What the guidelines say, the SVS guideline from the 2018 to 2021 still persist, like they still recommend to surveillance at the type 2 endoleak, which is not associated with the aneurysm sac expansion. But with the treatment, it suggests for the type 2 endoleak associated with the aneurysm expansion. How big of the expansions? In the SVS guideline, they did not mention about the size, but the ESVS 2019, they recommend the number as more than 1 cm as the sac expansion for the treatment. So the rationale for the SVS guideline 2021, they found the present or incidence of the type 2 endoleak after the EVAR is less than 25%. 30 to 50% can be resolved without any interventions, and the risk, the case of the complication focus on the persistent type 2 endoleak, which is the patent IMA number of the diameter of the patent lumbar artery, present of the accessory renal artery, middle sacral artery, and ongoing anticoagulant. And also the limited pre-existing sac thrombus volume is the high risk for the persistent type 2 endoleak. Let's see on the incidence by the area or by the region. We found that the Japanese or Asian populations, the type 2 endoleak incidence is quite higher than the another region in the world. But the rupture rate is still low in some area. They did not report of the rupture population. So we conduct the type 2 endoleak registry in our center. We focus on the natural history of the type 2 endoleak and also the predicting factor for the type 2 endoleak progress to the aneurysm sac expansions. From 2012 to 2020, From the 610 EVA cases, 143 developed type 2 endoleaks. 45 patients lost to follow-up, so only the 95 patients still remain in the study. We divided the patient into two groups. One is the complicated, which means the sac, aneurysm sac is increased more than 5 mm or need another complications. And also another group is the non-complicated group, means stable size and the regression of the sac size. Predicting factor, we analyze on the patient characteristic, the initial CT and on the follow-up CT imaging. And we classify the type 2 endoleak into 4 groups. One is the poor arterial enhancement, which means you cannot see quite clearly on the contrast media on the aneurysm sac, but see clearly on the venous phase, channeling, nidus type, and the complex types. And also we analyze about the measurement on the endoleak and also the feeding artery. On the result we found in our study, we found about 23.4% incidence of the type 2 endoleak, and also the endoleak with the isolated sac enlargement occur in 3.9%. And also the concomitant complication or another complications occur in 2.3%. So totally from the EVA cases, 5.2% have some complication with the sac enlargement and other type 2, type 1 and type 3 endoleaks. From the multivariate analysis, we found three factors that might associate to the sac enlargement. One is the longitudinal nidus length, which more than 90 mm, and the enhancement ratio, and also the pattern of the IMA. From this survival analysis, we found that the nidus length more than 90 mm, about 25% of the patient on this image. You can see in this level, the probability to develop the sac expansion is about 6 months. Which means if you found the sacs, the nidus length more than 90 mm in 6 months, 25% of the patient probably have the sac expansions. And the enhancement ratio, in the same way, in the enhancement ratio, we measure about the enhancement of the nidus here to compare with the endograph here. If the ratio is more than 0.85, about 50% of the patients we have some complication of the sac expansion at 6 months. In the contrast, in another way, if the ratio is less than 0.3, about you can see only the 25% in 4 years will stable in that situation. And the survival of the pattern or not pattern IMA, we found not significant different on the survival analysis. So in summary, in our study, we found the type 2 endoleak is occur about 23%, not different to the Japan study and another meta-analysis from the global populations. And the rupture rate in our hospital, in our center is 0. The sac enlargement is occur about 3.9% of the cases of performing EVA. So how about the preemptive IMA embolization? That is a topic that we should do or we should concern. So in this case, for the IMA, we use the reverse curve in this case, we use the OmniFlush. Thank you for the Dr. Chumpunut for this case. We use the OmniFlush to select and using the microcatheters. And we also use in this case, we use the the microcoil, two of microcoil. To embolize the proximal of the IMA. From the literature, since 2013, the embolization of the IMA pre-EVAR, we found that the reintervention rate and the increased the sac volume is better in the IMA embolization group. But in one case, there is the mesenteric ischemia and one patient passed away. Another study also embolization in the high-risk group in the part 10 IMA and also more than 2 of the part 10 lumbar artery, and also the significant decrease of the sac size at 6 months, 12 months, and 24 months. And also in this study, they recommend to coil embolization before the EVAR. Another study from Japan, also the same things. The endoleak is better. A reintervention rate is lower, and they recommend to selective IMA embolizations to decrease the incidence of the type 2 endoleak and the reintervention rate. Lately, there is the study from Leipzig German group. They do this thing. They did 139 aortic side branch embolization before the EVAR, and you would like to see the type 2 endoleak and also the abdominal sac shrinkage and reintervention rate after the EVAR. They did the technical success is about they did only the 76% of the initial patent aneurysm sac side branch, and the technical success reached to this one is the result. The endoleak in their study is occur only 5%, 4.3% increased sac size, and the number of the aneurysm sac side branch remaining patent after the embolization is the predicting factor of the progression of the complications. 86% have the sac shrinkage, and the diameter of sac the reduction is about 9.2%, 9.2 mm. One case passed away related to the aneurysm related death after the EVAR. This is the recent meta-analysis, systematic review and meta-analysis about the prophylactic aortic side branch embolization to prevent the type 2 endoleak in the JVS 2020. From the publication, about 3,000 publication, only the 13 retrospective cohort study was reviewed on this systematic review. The study is about medium to low quality, include in the systematic review. The result is the technical success of the IMA embolization is reached 84% and lower in the lumbar artery embolizations. Type 2 endoleak in the pool data, they occur 18% to compare 35% embolization and non-embolization group. How about the incidence? They prefer the embolization. Reintervention rate, also they prefer the embolization group, and all the sac enlargement significant and prefer in the embolization group. So in summary, in this systematic review and meta-analysis, the incidence of the type 2 endoleak is occur 18 to compare 35%. Reintervention rate is lower, and the sac growth is also lower. But there is one complication in one study. They found one patient passed away who is the status post-like hemicolectomy and die after the IMA embolizations. So in conclusions, Embolization of the side branch may reduce the incidence of the type 2 endoleak and reintervention rate with high technical success, particularly in the IMA embolization. But caution is needed in the patient who have some disturb of the collateral colony circulations. And study in this systemic review is lack of the high quality unbiased study in this field. So the question is, should we routinely perform embolization before the EVA? They still recommend the randomized evidence or for any benefit and the cost effective. This is the recent study from the RCT multi-center in Japan group. They still enroll and the result is not finished yet. The study is about the Clarify MA study is the RCT with the multi-center in Japan. So in the IMA embolization summary, I can say it is the significant lower risk of the type 2 endoleak, but this event is quite small number. Endoleak is occur about 20%, and another side branch of the aortic, like the lumbar artery, might have the significant caution for the type 2 endoleaks, and with the potential adverse event after the IMA embolizations. Post-operative death secondary to the colonic ischemia is reported, and the overall, even the overall incidence of the mesenteric ischemia is low. And also, if not only the IMA, with the lumbar artery embolizations, the patient might have the risk of the acute kidney injury by using a lot of the contrast media on embolizations. About the cost-related issue, with these 5% to compare with the routinely embolization, I think if we go on with the guideline of the current practice, we still recommend to use with the active treat with the case of the aneurysm sac growth. In summary, I can say the type 2 endoleak overall, the incidence is about 20%. But in the case of type 2 endoleak, need some interventions. In our center is only 3.5% with the sac expansions. The technical success in the literature of the preemptive embolization is quite high, 60 to 70%. But aneurysm sac rupture is less than 1% in literature. So I think routinely embolization or preemptive embolization before EVA to prevent type 2 endoleak still debate on the cost effective, and we need some data on the RCT in the future. Thank you.
Thank you very much. And that's add up a lot of some information for us to consider, I think, because we talk about the preemptive embolization quite a bit. Yeah, we'll talk about this later in the Q&A session. Thank you. Thank you, Ajahn Suracha. Next, Ajahn Somrat will introduce the next speaker, please.
So first of all, thank you, Dr. Suracha. And so the next topic will be the treatment of the endoleak type 2 after the T or EVA, presented by the Dr. Nantiskan from the Chulalongkorn Hospital. She's a young interventionist and a woman who has the energy to do the many cases of the peripheral intervention. So please welcome Dr. Nantiskan.
Thank you, Chairman, and also the Medtronic to inviting me to share this topic. I will share about the percutaneous treatment of endoleak type 2 after TIVA and EVA. For type 2 endoleak, some literature suggests that up to 30 to 40% will be persistent and need some treatment. It can be occur combined with other type of the endoleak, which is also the type 1 and also type 3. And you need to target the high flow leak first, because if you need the high flow leak, maybe the type 2 endoleak will resolve spontaneously. And you need to address the endoleak type 2 as an AVM. So the sac is the nidus, and also it has the arterial inflow and outflow. So complete embolization of all the sacs and the feeders will achieve the complete occlusion of the endoleak. And this case is demonstrate the combined type of type 2 endoleak and 1B endoleak, which was just observed during the intraoperative procedure. And you can see that there is the branch, the feeders of the type 2, and also the arteries that fills the iliac arteries, that is the 1B endoleak. So if you do not notice this and try to inject embolic material during the procedure, the embolic material may migrate down to the iliac arteries and may cause a major complication afterward. So treatment algorithm for the treatment of type 2 endoleaks combined with first confirm the diagnosis. This may be probably the most important step for the successful treatment of type 2 endoleak, and also use suitable treatment strategy and also the approach techniques, and also optimal selection of the embolic agents. For embolic materials that can be used in type 2 endoleaks includes coils, and also the bigger size can use the plug and the liquid materials such as the MBCA glue and also the onyx. For the glues, it permits rapid occlusion of the embolization, but it's a bit difficult to control. It may be cast the glue form at the tip of the microcatheter and does not reach to the target of embolization. Also, it can maybe reflux to the parent artery of the non-target embolization. And it can be used in adjunct to the coil to permit to enhance the slow flow of the sac. But each time after you embolize the sac, you need to remove the microcatheter rapidly. So that means you will lose the access of the nidus every time after each injection. So be sure to completely occlude the sac before remove the catheter, or you may need to start over again. And for onyx, it delivers more controlled delivery and decrease the risk of non-target embolization. It can be slowly injected, and it will fill the space of low resistance and the non-occluded segment, the space inside by itself, but it's quite take time procedure and relatively more expensive. For the approach technique, it can be transarterial or direct sac puncture or transsealing or perigraft. The transarterial approach is the mostly used approach, and particularly when you can trace the arterial feeder from the CTA, it's possible for the transarterial approach. It is a flow-directed approach, so it can demonstrate good overall evaluation of the vascular anatomy. But to use the transarterial approach, to get to the target, it usually takes long and tortuous paths of the microcatheter, so careful selection of microcatheter and wires are important. This is the case example, the type 2 endoleak from the IMA and also the lumbar artery. I selected from the SMA and passed through the marginal branch artery to get to the IMA. And after injection, if you just occluded the inflow here at the IMA, the lumbar artery that usually serve as the outflow will convert to be the inflow instead and will still perfuse the sac. So I need to fill up the sac first with the large size coils. And when the coils is inside and form the framing, I will fill up the space with glue to complete embolization of the sac. and then finish up with dense packing of the coil at the feeder of IMA. This is the final result. And this is another case of type 2 endoleak from the unoccluded from vascular plaque at the subclavian artery. I used retrograde transarterial approach and used microcatheter to navigate past the mesh of the plaque into the space of the endoleak and fill up the space with coils and glue. In this case, I used transradial access. So that means even this kind of cases, you can do it in an outpatient setting as well. Another approach is direct sac puncture. It can be translumbar on the back or transabdominal at the front. The translumbar is a little bit safer because there's a confined space and no intervening organs. I will do these cases in the case that I cannot trace the arterial feeders from the CTA or there's no access, like already occluded or already covered. It's easier access because you get directly to the sac. And after you get to the sac, you need stable delivery system to, you can manipulate more and embolization afterward. I use these kinds of introducer system. It's a transition from 018 to 035 system and can be put for a fence catheter inside and you can do embolization afterward. Even if you get through the sac, if you cannot demonstrate the arterial branches, it's strongly indicated the procedure will fail. In this case, after you get to the sac and injected contrast and you do not see the arterial feeders, if you put the embolization material inside, it will only expand the sac without embolizing of the feeders and it will perfuse the sac eventually. For the image guidance, ultrasound is the easiest way and it's most reliable because it's real time, but only limited cases can be done under ultrasound guidance because mostly it will be in the deep part of the body. Otherwise, you can use fluoroscopy and use anatomical landmarks as a guidance or more precise with cone beam CT with needle guide software or a CT guidance. This case, the endoleak sac is on the back and above the posterior chest wall. So it's very easy to see under the ultrasound guidance. After get to the sac and can visualize the arterial branch, I inject the onyx to fill the space and also the feeder. After remove the needle and checked with ultrasound, I can still see the perfusion of the sac. So I need another puncture, and this time I need to navigate the microcatheter into the untreated space, so I use more stable introducer as a sheath and also the microcatheter, and also finish up with tract embolization. And this case, it's clearly seen that the location will not be seen under ultrasound, so I use cone beam CT guidance to guide the needle directly to the nidus and can be successfully injected the glue. Another approach is transsealing. It's the same concept as direct sac access, but it's endovascularly purely. We will use the catheter through the small space between the graft and the arterial wall. It can be reduced the risk of extra aortic leakage and other organ injury, but it's quite technical, challenging. So I will consider this technique only if the transarterial or direct puncture is impossible. In this case, after inject the internal iliac artery, you can see the feeders from the iliolumbar artery, which is very small and tortuous and impossible to do under transarterial approach. So I try to do the translate sealing approach. You can see that this is important. The catheter should be engaged to the location quite firmly. If you use the single curve catheter in this case, the catheter will kick out once you try to put the guide wire up. So you need more stable catheter like the reverse curve. And after successful getting into the space with microcatheter and can demonstrate some branches, I can successfully injected the glue. And I will share some technique to achieve the dense coil packing for complete occlusion. You need to choose optimal coils property, sizing, and also the techniques. There are either pushable or detachable and fiber and non-fiber coils. For this detachable coil, it's deliver better control and it's retrievable, so it's enable the dense packing with precise deployment, and it has wide range availability of the length, but it's a bit more expensive, but some of them can be now reimbursed in Thailand and may require some more setup time in the beginning. For the fiber detachable coil, it has high thrombogenicity, but for the stiffness, compared to the non-fiber coil, it's a bit more stiffer, but it's much more softer than the pushable. For sizing, generally we use 20 to 30% oversizing, but it also depends on other factors like coil stiffness, also the stability of the delivery system and the packing techniques. The softness of the coil will be trade-off with the size, so the larger size will be stiffer than the smaller coils. And for the dense packing, you need stable of the system. You may use a long sheath for a better support and advance the catheter through the area of angulation and use microcatheter for the coil deployment. If you cannot achieve the stable system of the delivery system, try to use more softer coils and smaller coils to avoid the kickback of the catheter. And also packing technique. If there is no arterial branch for anchoring, you may use the first coil a little less oversizing to let it form the shape, and it will be the anchor for your second coils. But if you do have the branch, you can use more oversizing and packing it densely. And another technique is scaffolding and filling. Use a larger coil for scaffold and smaller coils to fill up the space. And always check for the compatible size of the microcatheter, which always indicated in the package. There are some new techniques also to get to the sac of the endoleak through the IVC or through the graft itself. It's transcaval and transgraft. For transcaval, it will use in the case that the endoleak sac is about the IVC and will be less bleeding complication, can be used under fluoroscopy and ultrasound. The needle that is used is the needle through sheath system, which is a Roche Uchida tip set. This is a diagram showing the steps. One approach for the IVUS and another approach for the needle. And once you completely embolize the sac, you can remove the sheath without tract embolization. And for the transgraft, you need a coronary laser catheter to puncture through the graft. So for the conclusion, please careful review of the image to first confirm the diagnosis and another to careful planning of the treatment. And if it is available, all the advanced technology like CT or cone beam, IVUS, or guiding software, these all can facilitate the procedure and make the procedure easier. And do not fix with one technique or one embolizing material. combining techniques will be useful as well. And it may occur frequently, so long-term surveillance is mandatory. Thank you.
Thank you very much. Thank you very much, Dr. Nantisikan, for a nice summary for us this morning. Dr. Somrat, I'm not sure you have any comments or questions for our speaker, please.
Yes, thank you, Dr. Bimprasi. So I think these two lectures from the Dr. Sorasha and Nantis can give us very detailed and informative technique to treat the endoleak type 2. So may I have a question for Dr. Sorasha? So in your data, interesting data, so you have the like a protective factor of the endoleak type 2 is a nidus length and the enhancement ratio. So you think can we use this data to predict the prognosis or can be used that for make decision? This endoleak maybe not to treat and no need the intervention if they have the protective data from your data set.
Yes, we found that on the multivariate analysis, we found divided because we use with the slope of the graph for the coefficients on the statistic, and we cut point at the number of 90 mm, 90 mm for the nidus length on the coronal view. And we found that after 90 mm, more than 90 mm, about 25% of the patients, we have SAC progression at 6 months and more after that. And also for the enhancement, we cut point at the 0.3, 0.85, and more than 0.85. If the enhancement ratio between the nidus and the graph more than 0.85, the patients 50% will have the SAC progressions at 1.5 years. But if the criteria is less than this, like if the patient have the enhancement ratio less than 0.3, that means in the graph about 50% will be stable at 4 years. Yeah.
So that was an interesting data. So may I have one more question about the preemptive embolization. So in my center, so I will not start with the preemptive embolization because before that we think this is quite a sophisticated technique. Before we doing the EY, sometimes we have to dealing with the so many branches that we have to embolize. So and according to your review the data, so you think this is a time that to do the preemptive one, or you want to do still the same way, waiting for the SAC growth in this era? So what is your comment right now?
For my comment, because of the proportion of the problem is just a small piece of the patient. I mean, in 100%, the patient that we have to treat with the type 2 endoleak with the SAC progression in our center just only 5%. So 5%. Right now, our practice is waiting for the SAC progression, but in some case, we just started our vascular surgeon colleagues. In some case, with the big size of the IMA, only the IMA, we try to embolize first, and it's just beginning, and we need to wait for the result.
Thank you so much.
Yeah, I think that the Dr. Saracha's data curved down our enthusiastic a little bit. we tend to be less excited about preemptive embolization, but I think it's not out yet, but cool down a bit. I think we need to have more data and more analysis about the cost effectiveness also, that Dr. Sumrat also mentioned. So I think that's we could still continue to do that. It may not change our practice just yet. The issue is that if we have type 2 endoleak, how successful we can coil it. We have many approaches: transarterial, direct sac puncture, Dr. Naniskan, can you give us some number how successful of the type we have type 2 endoleak, larger aneurysm sac. We sent for you to do coagulation. How successful? 100%, 80%?
Not 100% for sure, but as high as 80%, I can guess. The limit is that, as I said, if you do not see the arterial feeders from the CTAs and you need only access from the direct puncture, but once you get into the sac, you cannot navigate to the arterial branch or you cannot demonstrate it under the angiogram. That means you only embolize inside the sac and it will sneak in the thrombus without completely occluded. And the arterial that's still open will perfuse some space eventually. That's the strong indicator of the failure.
Now that's bring us some issue when we see the patients as a clinician. We see the patients type 2 endoleak, aneurysm enlarged, let's say 5 millimeters. We send for either of you, Dr. Saroj, 80% we fix it. About 20% of the cases we cannot eliminate that type 2 endoleak. Now what? Should we do conversion to open repair every case that fail embolization, or can we wait? And if we wait, how long can we wait? How big of the aneurysm that can we tolerate? Do you have any suggestion for that? Or we can try another session, multiple sessions, something like that. I'm not sure.
I think as we classify the type 2 endoleak in the 4 type, and we also have another atypical type 2 endoleaks. I think with the characteristic of the type 2 endoleak with the nidus type is quite easy to treat for embolization, even the coil embolization or glue embolizations. But with the complex type and with the atypical type 2 endoleak is even we success on the first procedure, if you have some recurrence on the later on follow-up. So I think we can divide it to the simple one or the complex one. If the complex one, I think the recurrence or unsuccess or unsuccess for the technical result.
Yeah, I think that's one of the difficult situations that we may not have a good answer yet. I agree with what Dr. Sorocha mentioned, because Dr. Sorocha just mentioned that the risk of the reported rupture rate was very low, not zero, but low. And then we had a lot of cases that have type 2 endoleak. We sent for embolization, we fix it, sometimes it reappear, and then the aneurysm keep growing. 1 centimeters, 2 centimeters more, we ask the patient for conversion. Some patients, they don't want to have open surgery. Then we kind of sitting there watching, and we were afraid that it would rupture someday. I'm sure that it will rupture someday, but there are some opinion, but this is opinion, I think, from the, if you can see the data from Europe or from US, the rupture rate was low. So there are many experts said that it's almost zero rupture. So they said that they would wait until like 2-3 centimeters bigger. I think that's dangerous though. But this is something to keep in mind for us when we see the type 2 endoleak. We fix it with coagulation. If we can't fix it, maybe not 5 millimeters as a cut point. We may wait a little bit more, I guess. But how much more? I don't know. we may convince the patient to convert to open repair. If we see it's bigger than 1 centimeter more than pre-op, I don't think we feel comfortable keep following. But there are people that we wait really, and then the anatomy change, the neck dilated. Now we have to fix that type 1A endoleak that follow the type 2 endoleak, something like that. So there are portions of patients that's still complex. Still we don't understand them fully, and we don't have a good. Even though this is a multidisciplinary approach, we need expertise. We need our friends, our team to help. But sometimes we still can't help. Doctor, yes, Ajahn.
Yeah. In that kind of cases that suggest a failure. I usually try to put some embolic material inside as well to promote the thrombosis, because the type 2 endoleak is a slow flow leak. So if you promote the thrombosis, maybe it will resolve spontaneously, and it can be delay the time that you can keep following up the patient and reduce the risk of rupture. And we will try again in the next session.
So thank you very much. I think that's all the time we have. Thank you, Ajahn Somrat, Ajahn Soracha, Ajahn Nasikan, for this nice session. And we will move on to the next session. Will be the last session. Ajahn Rawong will help leading this one of the complex issue. Thank you very much. Thank you.